Hello, hi, good afternoon. This is Felice D'Arco. I would like to thank you, the organizer, and Godwin for the invite. Unfortunately, I have to record this lecture because um, there were some problem with the time change in UK, but I will be connected for Q&A section in half an hour. So I would like to speak to you guys about pediatric congenital and vascular cases that, of course, they overlap. And I would like to focus on key radiological findings. So the first thing is, what is the structure of this talk? We have 5 key radiological findings and 5 lessons that I learned from this. And this will be a case-based presentation where I will show you the atypical presentation of common and less common neck masses in children, and then the typical presentation. And I will show you how, keeping the radiological reasoning sound and disciplined, you will be able to do the right diagnosis, even though sometimes the appearances are not completely usual. So this will guide you toward the differential diagnosis, and also I will give you some technical perspective on what protocol you should do and why. So let me start with the first key radiological finding, which is fat. So you need to decide if something is fat or not when you are looking at the mass in the child's neck or skull, because the fat can be a key element for the differential diagnosis. And as for other section of this talk, I will start for this key radiological finding, then to show you different kind of differential diagnosis. So first of all, this is a fetal scan, and this is 27-week old fetal scan with this mass, which appears mainly cystic in the orbit. So this was done at UCLH, which is an hospital close to Great Ormond Street, and they call this a lymphatic malformation or congenital cyst. Now, you can see why, because lymphatic malformation is typically located, among other spaces, is typically located in the orbit. And also, the orbital cystic congenital lesion are quite frequent. The problem is that this child will need a treatment, because you can see the proptosis, and depending on the diagnosis that we choose, the treatment as soon as the child will be born will be different. I will show you how big was this mass in this 3D reformat that was done in the fetal MRI. But what I want to point out is the appearances evolving over time. In pediatric neuroradiology, like in other in the head and neck, like in the brain, the child evolves in terms of an anatomy very, very fast. Like if you think about myelination that changes constantly in the first 2 years of life, with different speed in T1 and T2, you can understand how fast things can change. And this is what happened with this specific tumor here. So you see that here you have basically again later on 36 weeks, so basically 1.5 months down the line, they repeated the fetal scan. There is still proptosis, but the cystic mass becomes a bit smaller, and there are also some areas here that look more dense. Now this can be blood or can be something else, for instance can be fat, and we need to decide what's going on and why this lesion is becoming more and more solid. This is the first scan that we have postnatally. As soon as the child was born, they did this MRI, and again, cystic, predominantly cystic lesion, but it becomes more solid. And this area is hyperintense in T1. It can be blood or it can be fat. Of course, if you have a cystic lesion with blood, this will confirm your diagnosis of lymphatic malformation. However, if you have a cystic lesion, congenital lesion with fat, this will be a teratoma, completely different treatment. So you need much more aggressive treatment, and you can actually do a lot of this consideration even with the CT, because in CT you can distinguish between blood and between fat. So if you don't have an MRI, you could do a CT to distinguish this. But as far as the differential diagnosis is concerned, you guys need to think that when you have a cystic solid mass in a child, which is congenital, this can be a teratoma or can be a lymphatic malformation, and you need to distinguish between the two because the treatment is different. So we did repeat the scan, and this is a T1, and you see in T1 we use the hyperintensity of the fat as a passive contrast around the lesion. This area that was bright in T2 is also dark, bright in T1 is also dark in T2. The mass is still cystic, but look, it's becoming smaller and it becomes solidocystic more and more. So look how fast this is evolving over time. And now this area that is bright in T1 pre, if we do a fat saturated, FS means fat saturated sequence, loses its brightness, and this is how we can confirm that this is actually fat. And this solid aspect of the mass, apart from this area, is enhancing. So now you have a congenital solidocystic mass with fat in a neonate, which is the description of a teratoma. So even though this kind of teratoma presented in a very dynamic and um, mostly cystic appearance in the prenatal scan, you will see that keeping your reasoning and thinking about a solid cystic mass with fat will be almost pathognomonic description of a teratoma. And we published this case, but actually all these steps can be done with ultrasound and CT instead of MRI pre and postnatally. So this is the first thing. When you see something like that, solid cystic mass with fat at the center, this is typical of a teratoma. So remember this description: mixed solid cystic mass with fat content in a neonate or congenital. Think teratoma. Let's stay to these key radiological findings. This is fat. We have another child with an obstruction of the airways that present acutely at birth. Okay, this is a neonate. And look, here we have another congenital lesion that is mainly characterized by fat, presence of fat, with a fibrous stalk at the center. All right, so this is a lesion that it is again fat, is again congenital, but doesn't look like heterogeneously solid or cystic. Look mainly comprised by fat on CT. This is fat density and a central stalk. And when you do the resection, the histology shows exactly the same: a central stalk of fibrous tissue surrounded by fat. So what is the main differential? Is this a thyroglossal duct cyst? Probably not, because there is no fat in the thyroglossal duct cyst. Is this a teratoma? Possibly, but I showed you before the definition of teratoma is a solidocystic mass. In this case, we don't have a solidocystic mass. Is this a sarcoma? Be very, very unusual. This is not aggressive, and the sarcoma does not have fat. So this is a form of dermoid that is called airy polyp. And why it's very important that you diagnose an airy polyp dermoid, and why it's very important that you know that when you see a fatty mass surrounding a fibrous stalk, this is pathognomonic of airy polyp dermoid, because the airy polyp dermoid derives from the middle ear cavities, from the tympanic cavity, and then protrude. You see here, this is the eustachian tube, and then they protrude into the nasopharynx, obstructing the airways. And when you have something like that, it's so important that you tell the surgeon to track down this lesion into the eustachian tube so it will not recur. And again, this is from the paper, histologically always the same: stalk at the center, fat around. So my pearl is that you know your histology, you will guess the diagnosis. The second key radiological finding I want to speak about is blood. I told you before in this teratoma, we had this problem. Is this blood or is this fat? If you have a situation like that, two different cases. Let's again try to describe these lesions radiologically. So you have lesions that are cystic. These are big cysts, these are small cysts. They have different intensity, including fluid level. That means bleedings. So you have bleedings here, but also look at this small fluid level here or there. So both of these are multicystic with fluid level lesion and also transspatial. That means that they involve different spaces in the neck and head region. So if you have transspatial, mainly cystic lesion with fluid level, this will be the definition of lymphatic malformation, even though they look very different. This is microcystic, this is macrocystic. So this is exactly what you need to keep in mind, that there is a dynamic changes between the two, or same entity can present with small cyst or with large cyst. However, what we have in this case is that the entity will be exactly the same. Also remember that if you do sclerotherapy of the macrocystic lymphatic malformation, they can become microcystic, so dynamic evolution over time. So remember, transspatial fluid level, which means blood. What's the diagnosis? A lymphatic malformation. And this again is the same in MRI that I show you, in CT or in ultrasound. In UK, we don't do a lot of CTs because emergency department, they have MRI and they avoid radiation, but it's the same reasoning. So this can be useful even though you don't have access to MRI. So we have uni or multiloculated non-enhancing cystic neck mass. Remember, micro and macrocystic, transspatial with fluid level. Now, this is another lesion with fluid level. Important thing is, guys, when it comes to cystic lesion of the head and neck region, the most important thing is the location. So where are they? And fluid level is for sure the key radiological findings of lymphatic malformation. But this is not multicyst, this is just one cyst, and this is not transspatial. If you look at the CT, it's actually centered in the bone. So when you have a bony lesion with fluid level, what this is, even though in this case the location is quite unusual, this is the definition of a aneurysmal bone cyst. So remember, fluid level is the key radiological finding of lymphatic malformation. However, is also the key radiological finding of something else, in this case, aneurysmal bone cyst, because it's centered in the bone. So remember, location is the most important thing when it comes to cystic lesion. So remember, each one of these key radiological findings I am describing is actually typical of more than one entity, and you need to add further specification, further information, sometimes clinical, sometimes radiological, to do your diagnosis. In this case, you cannot use sclerotherapy, you need to resect it. Yeah. The third key radiological findings I want to speak about is vessels. So look at this case. This is a very important case where you have proptosis. You see the globe is prominent on the right, and there are multiple vessels here. This is post-contrast. This is normal T2, the T2 with fat sat, T1 with fat sat pre-contrast, T1 post-contrast with fat sat. Now, the vessels are the key radiological findings of two main lesion in the head and neck. One is the hemangioma, another is the AVM. Now, in this case, venous malformation, venolymphatic malformation, these are not cystic, that's fine. In this case, you need to decide if this is an hemangioma or an AVM, arteriovenous malformation. Why this is so important? Because if it's an hemangioma, the hemangioma will disappear. either spontaneously or with beta blockers. So it's an infantile hemangioma, quite common, doesn't matter. AVM, you need to treat it because it goes worse and worse, and it will actually create serious problem, erosion of the bone, and so on. So let's have a look here. What are the characteristics of this? There are too many vessels. We don't see a discrete mass. And these children clinically was worsening over time. Now, every time you see a lot of vessels, ask yourself, is there a mass that I can see or there is no mass? Because if there is no mass, this has to be actually an AVM. So no mass, aggressive behavior, a lot of vessels, even if you don't see the nidus between the artery and the vein, remember this is an AVM. So this was our case. Now let me show you how typically an hemangioma looks like. Most of the time you don't need the MRI, they will know just looking at the child. But as a general rule, large mass with a lot of vessels, no diffusion restriction. Diffusion restriction means aggressiveness. If you don't have diffusion, this is an ADC map, so everything that is bright is low cellularity, and homogeneous enhancement. So these are the four descriptions of the hemangioma: well-defined mass, homogeneous, internal flow void, and free diffusion. And you can do a screenshot of this, strongly enhancing mass, internal vessel. There are no calcification because calcification are actually typical of a venous malformation that again is treated with sclerotherapy, and they go in involution. This is from Deborah Schatkes, and you can see the differential diagnosis between hemangioma, AVM, lymphatic malformation, and also venous malformation. A venous malformation will have dynamic enhancement, is a mass that loves masticator space, so love the muscles, and there are calcification that you can see on CT or ultrasound. An hemangioma, triphasic growth, meaning that it disappears over time. Vessels, yes, but there is a mass, so this is a cellular neoplasm. AVM, there are vessels, there is no discrete mass, but there is lysis of the bone and overgrowth over time. We have seen lymphatic malformation, microcystic with hemorrhagic fluid level. Remember though, when you see a mass, it's not always an hemangioma or venous malformation. Look at this same location, bit more heterogeneity here with necrosis, but look at the diffusion restriction. The ADC map is very dark. This is a lot of cells, and this is an hemangioma, while the diffusion restriction here is typical or of an aggressive tumor. In this case was an infantile sarcoma. So look, bright ADC, less cellularity, benign tumor, hemangioma. Dark ADC, a lot of cells, aggressive tumor, infantile sarcoma. Radiological findings number 4 is the bony involvement. I showed you already the aneurysmal bone cyst. Look at this case. This is an infant with the mastoid lump here. They wanted to biopsy because they thought it was an LCH. There is enhancement and there is low ADC, which means a lot of cellularity. But this is an infant, so it's too young for Langerhans cell histiocytosis. So LCH stands for Langerhans cell histiocytosis. But because of the venous sinuses are very closest to here, they did also a CTV. We are not interested in the CTV per se, but look at the bony window. LCH, Langerhans cell histiocytosis, should show sharp erosive changes. In this case, there are permeative changes. This is an aggressive tumor going into the bone, destroying the bone. So when I saw this CT, I realized the difference from normal LCH. LCH loved the temporal bone, but look how it looks like. It's very, very lytic in the appearance. And this is when you see an high cellular because of the diffusion lesion in the skull base or the skull, you need to check the abdomen because this is the main localization of metastatic neuroblastoma. This is one case. That's another case with metastatic lesion. Look at the skull base here, very large. Here, enlargement of the vault. There was also metastasis in the eye, but you do need an ultrasound of the abdomen. This was the ultrasound. This is the MRI. This is an abdominal neuroblastoma invading the skull, showing diffusion restriction and mass. But the previous one was isolated, so it was much more difficult. And again, look at the permeative destruction of the bone, very different from the lytic appearance of the LCH, and also the dense ground glass appearance of fibrous dysplasia. So you have all the spectrum of bony changes on CT. Remember how important it is for you the use of CT as complementary diagnostic approach to the MRI. And then the DWI. I show you already how important was the DWI, but I want to show you in the last 10 minutes another important case that I learned a lot from. So this is 8-week-old with a lump in the skin of the head. You can see it here. This was very suspicious clinically for leukemia, and they did an MRI brain to check for intracranial involvement. Now, here, the fellow reported these are normal. Okay, there was no intracranial involvement, so we were fine. But you see the skull base and the masticator space here are a bit heterogeneous in both T1 and T2, but you cannot really call it. But look at the diffusion. The diffusion shows multiple areas, nodular areas of diffusion restriction in the scalp, in the masticator space, ocular muscles, and temporalis muscles here, and skull base in general. Demonstrated also in ADC. Of course, DWI bright needs to be dark in ADC. This was the leukemic nodule on the skin. So what you need to look, for instance, here, look at the orbit. You can see the nodule of restriction here with the posterior aspect of the lateral extraocular muscle being spared. So these are all leukemic nodules, unfortunately, that will have been missed unless you will have seen the DWI. So remember, DWI is very, very, very important. Is your friend, not only to distinguish aggressive tumor like sarcoma versus hemangioma, or to show the aggressiveness of metastatic neuroblastoma, but also in cases like that where the only abnormalities visible are on DWI. Finally, this is an AVM here. That's my son trying to read the scan. But the thing is that a child is not a little adult. So if you are using MRI and you want to do an MRI for lesions that are not in the brain but are in the head and neck region, you need to do the right protocol. And we wrote these guidelines for magnetic resonance imaging in pediatric head and neck. This is a consensus statement that has been endorsed by a lot of societies, and it's free to download on ResearchGate. So you can, download this paper and look at these protocols, because a lot of the scans done for head and neck pathologies in children are done by non-specialized head and neck radiologists, and they do the wrong sequences. So it's very, very important that you do the right sequences. So what 5 lessons I've learned? Solid cystic mass in a neonate plus fat, think a teratoma. The differential diagnosis will be a lymphatic malformation that is not solid and does not have fat, but fluid level, and is multicystic. Too many vessels. ABM can have arteriovenous malformation, but also hemangioma. One is very aggressive and need treatment. The other is very benign. They have different management. Remember, if you have no mass but aggressive behavior, AVM, mass is an hemangioma. Skull permeative restricting lesion in an infant. Think neuroblastoma. Do not biopsy. Do an ultrasound of the abdomen. Remember that DWI is your friend. and a child is not a little adult, you have different protocol for different pathologies, and you need to do it right. These are my acknowledgements. I really would like to thank Godwin and the society, the Nigerian Society of Neuroradiology, for this invite. Sorry about recording this lecture, but I really, really enjoy every time I do lecture for you guys, and please get in touch if you have any interesting case, or any question for me. Thank you again, and see you for the live Q&A session.